Hi, everyone. Nice to see you. I'm Pete Poullos. I'm a clinical associate professor of radiology and also the founder and co-chair of the Stanford Medicine Alliance for Disability Inclusion and Equity. And I'm just going to start this talk by asking you guys a question. For those of you who are physicians, how comfortable are you caring for patients with disability? Think about your training and your cultural competency, the physical accessibility of your office, the ability to make accommodations for different types of disabilities. This is the outline of what I'm going to be speaking about today. I'm going to define disability, its prevalence, briefly touch on disability and health disparities in general, the relationship between disability and cancer, and then the meat of the talk will be disabled women and cancer screening. So my objectives are for you to recognize patients with disability as a population with health disparities, to distinguish how disabled and non-disabled women receive cancer screening, and then apply the above to improve care for our patients with disabilities. So because disability is a foreign topic to some people and not frequently discussed in health disparities as other minoritized demographics, I just want to get quickly everybody up to speed. So what is a disability? The Americans with Disabilities Act defines a person with a disability as having a, quote, physical or mental impairment that substantially limits one or more major life activity. So this definition is very broad and can encompass diseases from diabetes to quadriplegia, schizophrenia to end-stage renal disease. The key is that it limits major life activities. And I also want to say that disability is diverse. So we have, the classic disabilities you think about, mobility, blind or low vision, deaf or hard of hearing, but it also includes things like learning disabilities, chronic health conditions, Crohn's disease or emphysema, ADHD, psychological disabilities like depression, and autism spectrum or neurodiversity can be considered. How many people have a disability? Well, depending on the definition, the age group, and the geographic location, and a host of other variables, worldwide estimates range from between 5% and 30% of any population. In the US, the CDC reports that 1 in 4, 61 million adults in the United States have some form of disability. And for those of you at Stanford, we published a survey in 2020 about disabilities at Stanford Medicine, and we also had 26% of respondents with a condition that would qualify as a disability under the ADA. So our population at Stanford reflects what you see in general. I'd also like to add before we go on an important statement from the Institute of Medicine. And part of my mission with SMATI is to disable ableism and this false binary between disabled and non-disabled people. And the Institute of Medicine states if one considers people who now have disabilities, people who are likely to develop them in the future, and people who are or will be affected by the disabilities of family members or others close to them, then disability affects today or will affect tomorrow the lives of most Americans. Clearly, disability is not a minority issue. And understand that disability is normal. It's a normal part of life. So now let's talk about disability and health disparities in general. Before I get to the data, I want to talk about ableism and discrimination against the disabled. So for most of human history, the perceptions of those with disabilities have varied according to culture. There's quite a bit of variation and stigma, with many cultures accepting people with disabilities as normal. Some societies have even revered those with disabilities. Ableism expanded with the rise of the eugenics movement and this analysis of a plethora of human traits and new definitions of normal, typical, or ideal. And this eugenics movement caught hold worldwide, but scientists in the US were instrumental in its development. And their ideas were extrapolated to the extreme in Europe in the early 20th century. But eugenics did not end after the Second World War. And in the US, forced sterilization, even of the disabled, was still legal up until 1979. And although the sterilization law was overturned in that year, prison sterilizations weren't banned until 2014. And stigma and stereotypes persist in our culture, not least of which is amongst ourselves as healthcare providers. So the downstream effects, the stigma, stereotyping, discrimination, and ableism are the health disparities we witness today amongst the disabled. Adults with disabilities are more likely to be obese, to smoke, 3 times as likely to have early onset heart disease and to have diabetes. They're also more likely to have no leisure time, physical activity, to be unemployed, in poverty, victims of violent crime. And of course, because we're talking about cancer today, obesity and smoking are, of course, big cancer risk factors. Now we'll talk about disability and cancer. This is the first of 2 disclaimers I'm going to give in this talk. So our collection for disability and cancer is suboptimal. People with disabilities are often excluded from randomized clinical trials. So it's hard to actually find the data in research. Diagnostic codes don't provide that much information about function. The research is mostly from population-based surveys, which suffer from issues of disclosure. So willingness to participate is adversely affected in some instances by culture, gender, race, ethnicity, socioeconomic status, and within disability, not all of them are studied equally, and intellectual disabilities in particular are underrepresented at every level. So mostly in the form of surveys and qualitative interviews, relevant to my talk, more is known about women in cancer screening than men, and importantly, downstream results such as diagnosis, treatment, outcomes are even less studied. And AI is a part of this conference, and there's really very little written about disability, AI, and cancer screening. So maybe we need to do something about that. So what do we know about disability and cancer? This is a study by Lisa Iazzoni published in 2020, examining the association between cancer and disability. And she focused on 4 cancers that could present with non-specific symptoms, which could be potentially conflated with aspects of disability. And these were colorectal, non-Hodgkin's lymphoma, prostate, and ovarian cancers. And the data were obtained from a national health interview study, survey from 2010 through 2017, with a total of over 259,000 respondents. And a word about the NHIS for those of you who are unfamiliar. This is an in-person survey conducted by trained US Census Bureau interviewers. And they interview non-institutionalized civilians. And Dr. Iazzoni found that those with pre-existing disabilities had higher rates of cancer than those without. And this is a table from her study showing that those with pre-existing disabilities had significantly higher rates of cancer than those without disabilities, and were also diagnosed at an older age. And so on the left side, we have the 4 different types of cancer. On this top row in gray, we have disability status. So the first column is no disability. Next, movement disorders, movement difficulty. And then CAL is complex activity limitations, along with their respective p-values. And the rates of cancer are in the data table in blue. And you can see that for each of the cancers, the rates are higher for those with movement difficulties and CAL compared to those without disabilities. So for example, the rate of colorectal cancer for those without a disability was 0.24, but the rate for movement difficulty was 0.85, and for CAL 1.02. Now the bottom half of the table in yellow shows the age in years at cancer diagnosis, which is significantly higher for those with disabilities, ranging from 3 to 15 years older than the non-disabled. So for example, women with movement difficulties, men with movement difficulties are diagnosed with prostate cancer at 66 years old, compared with 62 for those without disability. And most of these are highly statistically significant. This slide from a separate study, also by Dr. Iazzoni from 2021, shows the rates of cancer and age at diagnosis of patients with breast and cervical cancer by disability status. And the rates of cancer were higher and age at diagnosis older in those with disabilities. So the top half of the table is for breast cancer and the bottom half is for cervical. And as you can see here, patients with movement difficulty and complex activity limitations had rates of breast cancer of 3.5 and 3.6% compared to those with no disability at 2.2%. And the age at diagnosis of those with disability was also higher than those without, 61 compared with 53. And the rates of cervical cancer for those with MD was 0.8%, and 1.0% for the disabilities, and compared to 0.6% for those without. And their age at diagnosis was also significantly higher, 38 and 39 years compared with 29 years for those without. And all of these were statistically highly significant. If you're interested in learning more about Dr. Iazzoni and her work, she's very interesting. She went to medical school, I think, in the 70s or 80s and developed multiple sclerosis. And at that time, becoming a physician with a disability was thought of as impossible. And so she was never able to obtain a residency or practice. And so she's devoted her career to studying health disparities in patients with disabilities. And we interviewed her for the Docs with Disabilities podcast. And she has a fascinating interview there for those of you who are interested in learning more about her. And finally, disabled women and cancer screening. So this is my second disclaimer about the studies of cancer screening in women with disabilities. So articles summarizing the literature make the point that research studies are heterogeneous. The disabled are a heterogeneous group. Two people with the same diagnosis may have very different activity limitations. The definitions of disability vary between studies with different scales of severity or impairment that might qualify as a disability. And screening guidelines vary from country to country and over time. So that being said, most studies do show that there are significant disparities between disabled and non-disabled women for cancer screening. This table is from that last study I talked about from 2021, and it demonstrates that women with disabilities have lower rates of receiving screening, mammograms, and Pap tests. So the top half is for mammography, and the bottom part is for Pap tests. And up top, we see that 83% of women without disabilities, 30 years or older, had a mammogram in the past 2 years, compared with 77% of women with movement difficulty and 71% of women with complex activity limitations. And on the bottom part of the table, we see that 81% of women 18 years or older without disabilities had cervical cancer screening in the past 3 years, compared with 68% of women with movement difficulty and 72.5% of women with complex activity limitations. This last value here, the 72.5 years, was not statistically significant. Mental illness is often overlooked in discussions about disability. So the next study I want to talk about is a retrospective one from Iowa that studied women of screening mammography age from 1996 to 2001. There's a large sample size of 191,000 women, 31% of which had a mental disorder diagnosis. Most of these were mild or medium in severity, 85% mild and 12% medium. Only 2% were high severity. The control group was 131,000 women without a mental disorder. So this table shows the odds ratios for the receipt of mammography according to the severity of mental illness. So the receipt was 76% for women without a mental illness diagnosis, and 81% in those with a mild mental illness, 76.8% for medium severity, and 69.7% in those with severe mental illness. And adjusting for other variables, the odds of receiving a mammogram were lower for women with medium or severe mental illness. So in the adjusted analysis on the far right column, we see that there is no significant difference between women with mild mental illness and no mental illness. However, the odds ratios of receiving screening mammography for those with medium and severe mental illness are highly statistically significant. This study is highlighted on the CDC's disability website. It's a January 2017 study by Dr. Brooks Steele and colleagues. This one also used NHIS data, and the 2013 survey included a cancer control supplement. So the sample size was 15,000 adults with known disability status. 12,500 of them did not have a disability. 2,500 of them had at least one of 4 types of disabilities, and they included hearing, vision, cognitive, and mobility. That made up around 17% of the total. And the 2013 USPSTF screening recommendations were used to define what counted as appropriately screened. Women without disability had Pap smear rates of 81%. The range of Pap test use for those with disabilities ranged from 66 to 80%. And the odds ratio for any disability was 0.77. And for mobility, a limitation is even lower at 0.58. The data for screening mammography tell a similar story. 73% of women in their sample without disabilities received a screening mammogram. And for those with disabilities, it ranged from 61 to 67%. In this particular study, speaking of heterogeneity within the literature, in their multivariate analysis, the odds of receiving mammograms were lower, but not statistically significant. So what's wrong with this picture? So there's another study that goes more deeply into the feelings of people with disabilities around the process of diagnosing their cancer. So these people have already had diagnosis of cancer. It was a qualitative study of 20 participants with pre-existing mobility disabilities who were subsequently diagnosed with the cancer. And there were 5 major themes that arose. These were the inaccessibility of diagnostic equipment, so negative attitudes of staff around accommodating disabilities. They felt that their signs and symptoms of cancer were dismissed as emotional or psychosomatic, and that the signs and symptoms were sometimes misattributed to their underlying disability, which is a mental error called diagnostic overshadowing. They also stated that the clinic personnel were often unwilling to transfer them out of a wheelchair or help them onto a table, for example, for fear of malpractice or personal injury lawsuits. And so the conclusion was that these sorts of barriers and assumptions can contribute to diagnostic delays, insufficient workup, and poor quality of care. So lastly, what are some potential solutions? So we can install accessible medical equipment, such as wheelchair accessible weighing scales, height adjustable exam tables, and transfer devices such as a Hoyer lift. For specific equipment requirements, there are readily available standards available from the federal government. We don't have to go about doing this blindly. We can also develop procedures for appropriate patient positioning, such as for MRI or biopsy. A lot of things can be solved with better training. So staff trainings should include material on disability, cultural competence. We also need to develop policies and procedures that are proactive. We should ask about patients' accommodation needs. in order to anticipate any accessibility challenges before their appointment. But we need to train staff in their legal responsibilities to accommodate patients and how decisions about reasonable accommodations are made. And we also need to train them to transfer and position our patients, techniques for comfort, as well as to reduce risk of injury to staff and patients, and to improve the quality of our diagnostic tests. For the dismissal of cancer signs and symptoms as emotional responses, we can train our staff about the risks of misattributing signs and symptoms to psychological factors. We can improve training about disability bias through having our staff take online disability implicit association tests and trainings. And for misattributing cancer signs and symptoms to the underlying disability, we can also be trained. Just being aware of diagnostic overshadowing as a possibility can improve it. We can also consider consulting with physicians who are experts in disabilities, such as physical medicine and rehabilitation doctors. And lastly, for attitudes, we can train our staff about patients under the ADA. So with that, I will end and ask if people have any questions.
Thanks so much, Pete. Does anyone have any questions?
Yes. The what's higher? Oh, cancer rates, yes, are higher in disabled patients. Yeah, so I mean, it's multifactorial. There are like the psychos or what am I trying to say? The factors around their health, social determinants of health. So like obesity, smoking, lack of exercise, those things are part of it. There's been studies showing that like there's higher oxidative stress in some patients with disabilities, like for example, with schizophrenia due to chronic stress. And then there's the I think the lack of or cancer screening also plays into it, and that's due to I mean the process from start to finish can be very daunting for people with disabilities, just like receiving the written or visual or verbal instructions, not being able to read, not being able to hear instructions on the phone. That has something to do with it. Poor access to transportation, physical inaccessibility of clinics. So sometimes it could be as simple as like getting in the front door. I mean, there have been surveys of physicians that where people call around and pretending to be a patient and asking about they tell the clinic that they're in a wheelchair and that they can't walk, and like only 30% of physicians' offices have welcomed them as patients. Most of them just say simply like, "I'm sorry, our office isn't accessible," or "We don't have the staff to transfer you," or "Our exam tables don't adjust." There are stigma and beliefs around disability. Like, for example, some doctors feel like women with physical disabilities are not sexually active and therefore may not need a pap smear. And so there's a whole host of factors.
Yeah, thank you for that. Is anyone else?
Going once?
Going once, going
Going
twice?
twice?
I have one question. You mentioned about existing policies and regulations which are available, which can be used as a guideline. Do you think those are sufficient to train the staff, or those also need to be modified? That's my first question. And second question is, you talked about the certain physicians they don't welcome sometimes the disabled patients. Is it mainly due to the like less funds? They don't have enough funds to train the staff accordingly or to get those types of the resources in their clinics? Do you think that it's also the question related to the fund availability of the funds for these things?
The availability, okay, so yeah, so the first question refers to like the whether or not the federal standards on accessibility are adequate or not. Um, you know, I think that with the Americans with Disabilities Act, we've seen that that provides a floor, not a ceiling. So there are a lot of accommodations that are mandated by law that people are legally obligated to follow and they don't follow. So just doing something, with these federal, just adopting these federal regulations would make a significant improvement in the situation. I mean, it's very low hanging fruit in these instances. So I would say no, they're probably not enough. That in order to move towards true accessibility, we need a huge cultural shift and a way to combat persistent implicit bias that really hasn't budged for people with disabilities. It's improved for lots of other minoritized groups, but for some reason, it doesn't seem to budge with disabilities. So I would say, yes, it's a good start. And then the second part of your question was about whether or not we have funds to train people. I think it's very cheap. I mean, people know nothing about disability. It's so when I give talks, this is why, like, when I start my talk, I start like, what is a disability? I don't know how many people ever really think about it. It wasn't even included in health disparities toward until Healthy People 2000, I think. And we're still fighting, like the National Council on Disability is still fighting to have disability included consistently with health disparities research. So what I'm saying is, like, we're a long way off, and just engaging. I mean, there are disability groups all over the country that would be willing to train, and probably, for not that much money, I would say. Although I should say we should be paying these people, right? Instead of just expecting them because they have a disability to come and train our staff. I mean, it's often hard-won expertise, and we don't want to do any more minority tax than we already do. You can hire me.
That's a good way to put it, the tax.
Sorry, can I ask a question?
Yeah.
Thank you for the presentation. I'm wondering, because you mentioned there is some cases which they excluded from their study. I'm wondering, is there any possibility to use AI to address some, I don't know, artifact or problem in imaging, any type of imaging for these disabled people, which you can address them with AI? Do you have any idea?
Yeah, so the question is, can we use AI to improve the image quality for patients with disabilities?
Because there is sometimes some type of artifact, maybe because of existence of some implant or anything else, which we can address them by AI. But I don't know, do you have any idea regarding this?
Nobody has looked at this question. I was starting to think about it, but I couldn't find anything really in the literature. I think that we should just be including people with disabilities in our training data sets. I think that probably in a lot of cases they're excluded, just like we see and probably have heard today from the other speakers about like how homogenized and non-diverse our data sets often are. And so understanding that if you're excluding people with disabilities, that's 25% of the population that you're leaving out. And there's a lot of intersectionality with disability and like racial and ethnic minorities and other populations. And so, I think that we try to make these data sets really pretty, but when they're pretty, how accurate are they or generalizable?